Like and subscribe channel Concepts of Oncology for learning about various cancers.
I am presenting a case of 48-year-old lady resident of rural area presenting with chief complaints of painless progressively increasing jaundice since last 1.5 months. Patient was apparently asymptomatic 1.5 months back. When her husband noticed yellowish discoloration of her eyes, she noticed that her urine has also become dark yellow in color. Yellowish discoloration of eyes and urine increased in intensity during last 1.5 month. Patient noticed her stool has become clay-colored and she also has itching all over body since last 1 month. Patient is having complaints of decreased appetite since last 1 month. Her diet has reduced to half of previous diet. Patient had no complaints of pain in abdomen, vomiting. However, mild nausea is present, melena, hematemesis, chest pain, cough, any abdominal lump, altered bowel habits.
You said patient was apparently asymptomatic 1.5 months back. Why apparently?
Apparently because patient may be having disease onset before 1.5 months back but became symptomatic later.
In which condition is there yellow discoloration of skin, apart from jaundice?
Hyperkeratonemia may lead to yellow color to skin.
So how will you differentiate between yellow discoloration of skin due to hyperkeratonemia and jaundice?
In hyperkeratonemia, sclera is spared.
What does clay-colored stool means?
Clay-colored stool is due to lack of stercobilinogen in stools. It is grayish in color.
Is this surgical jaundice or medical jaundice?
This is surgical jaundice.
Your reasons?
Patient is having dark yellow color of urine with itching and clay-colored stools. These suggest bile duct obstruction.
You said patient is having nausea, so her decrease in appetite may be fear of eating due to nausea.
Patient has both decreased appetite and also nausea.
What is melena?
Melena is passage of black, foul-smelling, tarry stools.
What is tarry?
Tarry means like a coal tar, viscous.
How stool becomes thick viscous like coal tar?
In upper GI bleeding, red blood becomes altered due to acid and enzymes to black in color, and due to churning of altered blood in food in small and large intestine by peristalsis, a thick viscous black stool is formed.
Melena in jaundice patient, what does it signify?
Melena in obstructive jaundice may be due to several reasons: shedding of ampullary or duodenal tumor, peptic ulcer bleeding, bleeding due to deranged coagulation.
You said patient's diet decreased to half, but her bowel habits are normal. We usually expect such patients to have constipation as fiber and liquid intake reduces.
Normally we would expect constipation in such patients. In past history, there is no history of similar illness in past and no history of any major illness or surgery in past. There is no history of any chronic drug intake.
What drug intake is important in such cases?
Any history of anti-tubercular treatment or treatment for any other chronic disease. In personal history, patient is non-smoker, non-alcoholic, no history of chewing tobacco. There is no history of any other addiction or allergy.
Why have you asked drug allergy?
Patients may have allergy to certain drugs which then must be avoided during their treatment. In obstetric history, patient is multipada with 4 children, all children born via normal delivery and all are alive and healthy. Patient since last 6 months is having prolonged gap between periods with scanty bleeding. There is no complaints of any lower abdomen pain or lower back pain.
What is relevance of this?
Patient may be having menopause.
What is your provisional diagnosis or differential diagnosis based on history?
In a case of painless progressively increasing jaundice, I would like to keep differential diagnosis of periappullary carcinoma, cholangiocarcinoma, gallbladder cancer, pancreatic head cancer.
Is gallbladder and pancreatic head cancer painless?
Usually gallbladder cancer and pancreatic head cancer are associated with dull aching pain in abdomen, plus there can be backache. This is because they cause jaundice late in course after reaching certain size. But gallbladder neck malignancy can cause jaundice even when small in size due to early involvement of bile duct.
Which part of conjunctiva?
Icterus is seen in bulbar conjunctiva.
When there is deep jaundice, how can you examine for pallor? You cannot comment on pallor. If there is deep jaundice due to yellow tinge to palpable conjunctiva.
There is yellowish hue to her skin, no clubbing, no cyanosis.
Again, it is difficult to comment on cyanosis in case of deep icterus.
Mild pedal edema is present.
You have to describe pedal edema in detail.
There is pedal edema up to mid-leg, pitting type with skin normal, no tenderness.
What does it signify?
Pedal edema can be due to hypoproteinemia, as patient is having decreased appetite, or can be due to any coexisting cardiopulmonary disease. There is no significant lymphadenopathy in cervical, axillary or inguinal region. There is especially no left supraclavicular node present.
Why specifically left supraclavicular lymph node?
Left supraclavicular node is called Virchow node. It can be enlarged in gastrointestinal and testicular malignancies. Cancer cells can travel by cisterna chyli to thoracic duct and then to point of insertion of thoracic duct in IJV subclavian vein junction. Virchow node is present here.
Virchow node, where is it present exactly? Supraclavicular is big area.
Virchow node is actually present above medial end of clavicle just lateral to IJV.
It belongs to which level?
Level 4. On systemic examination, in cardiovascular system, BP is 126 by 78 mm mercury, pulse is 89 per minute, regular normal volume, no added sounds present. In respiratory system, respiratory rate 16 per minute, no accompaniments, bilateral chest clear with normal vesicular sound, musculonervous system examination is normal, no tremors, gait is normal, no spine tenderness, cranial nerves intact. My findings are confined to abdomen on inspection. Abdomen is flat, with all quadrants moving equally with respiration, no scar mark present in abdomen, no dilated veins, umbilicus central and inverted, a fullness is present in right hypochondrium moving with respiration. On palpation, no local raise in temperature, no tenderness present in abdomen, a lump is palpable in right hypochondrium, globular in shape, 4 by 5 centimeters in size, moving well with respiration, firm, smooth surface, well-defined margins, non-tender, finger cannot be insinuated between lump and costal margin, no other lump palpable in abdomen.
Finger cannot be insinuated between lump and costal margin. What does it mean?
It means lump is either arising from liver or attached to it.
What is this lump?
It looks like gallbladder lump,
Why is it not liver?
as it is globular in shape. On percussion, there is dull node on percussion over lump and is continuous with liver dullness. Liver span is 10 centimeters.
Is it normal liver span?
Yes, it is normal liver span.
What does it indicate?
It means there is no hepatomegaly. There is no shifting dullness present.
What does it mean?
It means there is no signs of ascites, no fluid thrill.
Can both shifting dullness and fluid thrill be present at same time?
Fluid thrill is present in tense ascites.
You said abdomen is flat, then, is there need for checking fluid thrill in non-protuberant soft abdomen?
No. On auscultation, bowel sounds are normal 2 per minute, no brood over lump. Perectal and pervaginal examination is not done.
What will you look for in pervaginal and perectal examination?
We will look for any pelvic mass or fullness in fornix due to ascites or cul-de-sac deposits.
What are these deposits called?
Bloomer's shelf.
What is your diagnosis? Would you like to keep differential diagnosis or provisional diagnosis?
I would like to make a provisional diagnosis of periampullary cancer.
What are your points in favor?
My points in favor of periampullary cancer are old age, painless progressively increasing jaundice, globular smooth gallbladder lump.
Can it be due to stones and common bile duct?
In stones with jaundice, gallbladder is not palpable.
Which law is this?
Courvoisier's law.
What does this law states?
In a jaundiced patient, if gallbladder is palpable, it is not due to stone disease.
Can there be exception of this law, when gallbladder is palpable with jaundice, due to stones?
When there is double impaction of gallstones, one in bile duct causing jaundice and another in cystic duct causing mucocele of gallbladder.
Why this is so that gallbladder is not palpable in case of bile duct stones?
Because due to cholecystitis, there is fibrosis in gallbladder wall limiting its distensibility.
Why not pancreatic head cancer?
Because pancreatic head cancer, if it is not in vicinity of ampulla, then its size is few centimeters to cause compression of bile duct. Such large pancreatic cancer usually is not painless but usually is associated with backache and dull aching pain in abdomen.
So, how will you proceed?
I would like to confirm my diagnosis by getting basic blood tests and radiology examination. I would like to do complete blood count, liver function test, kidney function test, PTINR, viral markers, and then proceed with ultrasound abdomen.
What does each investigation would reveal?
Blood count would show any sign of anemia or ACE counts may show developing cholangitis. LFT would show status of jaundice.
What are components of liver function tests?
Total bilirubin, direct and indirect, SGOT-SGPT, alkaline phosphatase, serum albumin and protein, prothrombin time and INR.
Why do we need INR? Isn't prothrombin time sufficient?
Each lab calculates prothrombin time using their own lab control time, which may differ. Hence there can be variation in PT from different labs and so difficult to compare. So INR is calculated. It is ratio of patient's PT and lab control PT. This can be compared among different labs.
What picture will you get in LFT in this case?
Total and direct bilirubin and alkaline phosphatase will be raised.
Can SGOT and SGPT get raised in obstructive jaundice?
There can be mild elevation of SGOT-SGPT in surgical jaundice due to mild liver cell damage caused by black pressure in biliary system.
Suppose in USG there is dilatation of common bile duct till lower end with no mass and rest is normal. What will you do next?
Since there is dilatation till lower end, so there is obstruction in lower end. If no mass is visible in USG and distal end of CBD due to bowel gas, we would get abdominal CT scan.
Contrast or non-contrast?
Both IV and oral contrast.
So we did a CT scan and there is mass in periampullary area 3 cm in size. Rest normal.
This is then case of periampullary carcinoma. We will look for resectability.
How do you decide resectability in periampullary cancer?
We will look for involvement of superior mesenteric vein and artery involvement.
Which would be more important for resectability, artery or vein?
Artery as vein can be resected but arterial involvement means inoperability.
Is there any special CT scan for small periampullary tumors?
It is called pancreas protocol CT scan. It has thin slices with water as oral contrast and 3 phases of imaging: early arterial, late arterial and portal venous phase.
In which phase is tumor best visualized?
Late arterial phase.
And liver mets?
Portal venous phase.
Why so?
Because liver mets are supplied exclusively by arteries, hence in portal venous phase due to enhancement of liver parenchyma, mets appear hypodense.
What does early arterial phase shows?
Early arterial phase shows arterial anomalies.
What if there is no mass present in CT but dilatation of CBD till distal end present?
In this case where we have suspicion of periampullary cancer and no mass is visible on CT, then endoscopic ultrasound is done.
Will you do preoperative stenting in this case as patient is having jaundice?
Inoperable periampullary cancer, pre-op stenting can increase morbidity and mortality by infecting the bile and so increasing septic complications. Hence it is avoided.
So in which cases would you go for pre-op stenting in periamp?
When neoadjuvant treatment is planned or patient cannot undergo surgery due to any reason like persistently deranged INR or not giving consent for surgery.
Would you like to go for pre-op FNAC?
We can go for FNAC, but negative FNA cannot rule out cancer, as pancreatic cancer is desmoplastic tumor with lot of stroma and less cellularity, so FNA can come negative.
What route will you adopt for FNA?
We will do endoscopic ultrasound-guided FNAC through duodenal wall, as duodenum will be resected in surgery so needle track seeding is avoided.
What surgery will you plan in this case if it is operable 2 cm periampullary carcinoma?
I will do pancreatoduodenectomy, Whipple surgery.
Classic Whipple's is or any modification?
We can do pylorus-preserving pancreatoduodenectomy in small periampullary cancer.
Which is better?
Both are equal from oncological perspective and in terms of morbidity.
What are special pre-op preparations done in jaundiced patient?
We will hydrate the patient well, give glucose infusions, correct coagulation profile, start pre-op breathing exercises, do cardiac and pulmonary risk assessment.
How will you correct deranged coagulation profile?
By vitamin K injections, plasma transfusion.
What structures are resected in Whipple's?
Distal stomach and pylorus, common bile duct with gallbladder, 15 cm of proximal jejunum, pancreatic head and uncinate process.
Why is gallbladder removed?
Gallbladder is removed as after distal gastrectomy. Chances of gallstones increase plus hepaticojejunostomy is usually not done in mid-CBD as vascularity is least in mid-CBD.
What are the various anastomosis done?
Hepaticojejunostomy, pancreaticojejunostomy, gastrojejunostomy.
Which is most important among these?
Pancreaticojejunostomy.
Like and subscribe channel Concepts of Oncology. Here you will get video lectures, questions, case discussions, case presentations, high yield facts, operative steps and much more.